and the correlation of the both. Dr. Leighton, it's great to have you here, and show us your case, please.
Good morning, everyone. I'm happy to be here. So I'm going to present a case of what we call the neglected thoracic spine trauma. This is a patient who got
and the correlation of the both. Dr. Leighton, it's great to have you here, and show us your case, please.
Good morning, everyone. I'm happy to be here. So I'm going to present a case of what we call the neglected thoracic spine trauma. Okay, so let's start up. So this is JN, 18-year-old gentleman, male who came with a history of having fallen from a tree in 2020 and sustained a T12 point fracture. And according to him, then he was told that there wasn't much, but he had an injury that involved the T12. He sustained actually a burst fracture, which, from the history, he probably, from there he was explaining it, he had this just a probabilistic score of around 5. At that time, he was told that he needed to have surgery for the back, but he didn't have the funds, so he didn't show up, and therefore was put on a TLSO, which he didn't buy. So that was 2020, that's 4 years ago. So next presentation, he comes to me in 2024 with a whole year of progressive weakness and numbness of the lower limbs, especially on the right. And he says that now his gait was abnormal because now he was walking differently, and he had to use even walking aids as a result of that. He had no bowel or urinary symptoms, and now his back was bending forward. At this time, he didn't have any other significant history, no history of smoking. He was a healthy young man with a good BMI, and he says that he was actually very active post-injury with no history of drug use or alcohol. So in 2024, he had this high-stepping gait, and he was using crutches with diminished sensation of the right, involving the lower limbs and the feet, especially the dorsum of the feet. I'm just going to show a chart here of his clinical examination, which showed that most part that was involved was actually the lower limb, especially from L to downwards. He also had a positive clonus and a Babinski sign on both lower limbs, and also the power was reduced in the hips and the knees below. The upper limbs were okay, and he was able to sense bowel fullness he could be able to sense, and there were any deficits in the upper limbs. So when he came, these were his X-rays that he had carried from 2020. I don't know if they are visible, but actually you may not notice. You may not notice much of the injury there. But now when we look at the images for 2024, when the symptoms began, you can actually see like a wedge on around T12 there, which when we look at the MRI, you realize that actually he had also the posterior discal ligamentous injury. And this is still the X-ray. You can see the bed there, loss of the balance sagittally, and this image even shows it better. And from this, you can actually see changes in the cord. You can see the myelomalacia there, and this actually can explain his symptoms on the lower limbs. From this, it's a node fracture, yes, but probably it looks like it was actually unstable burst, but with involvement of B2 also, because the posterior discal ligamentous injury was also involved. So this was a possible more of an A3 and B2 according to Vaccaro Chapman AO classification. So these were the images. We can actually see now the burst is even more visible. We can see that it's coming posteriorly, coming to involve the cord and therefore compressing the cord. And this could be the reason why the patient was getting myelopathic. So at this point, so these are the axial images. You can actually see now the reduction of the cord space, and this goes hand in hand with what we can be able to see on the other sagittal images. Just going through the same images here. So when he came now, he was having this kyphosis that was becoming worse with time, and therefore that's the point that we decided that it was important actually to intervene his problem. So we went in and through the, posteriorly. I did do a corpectomy, but I did a posterior decompression and stabilization and just a laminectomy that level. And I was able to fix and actually attain the balance, attain the curve, which doesn't look so bad. And I was able actually to get some pedicle screws through also the injured vertebra. So the patient currently is, not much changes so far, but is happy with the surgery. Yeah. Dr. Chapman.
So, is my microphone on? Yeah, good, okay. John, so good to have you here. So there's so many things to discuss, and again, we're pressed for time. Dr. Leitner, thanks for this very illustrative case. I'm going to ask you a first question. Again, we can't go into too much traumatology, but this goes to your talk also. How many columns does the spine have? 2, 3, number X? Because this so much pertains to our efforts at classification, understanding what goes wrong with the spine and its basic function. So how many columns does the spine have?
Are you asking me?
Yes, Dr. Dimar, yes.
Oh, well, depending on whether you believe in Holdsworth or Denis, there's 2 or 3.
But I'm asking you. You're a very wise man. You have an unusual connection, combination of biomechanics, anatomic, and spine common sense.
Well, no classification system is better than good judgment, okay, and understanding the biomechanics of the original injury. This gentleman probably had a TLIC score that was a little bit higher than 5, because almost certainly the posterior ligamentous complex, which is most important at the TL junction, was probably torn. And it was combined, it's a flexion compression injury, so he's got a burst injury with an added PLC injury. So it's more than just a burst fracture, which resulted in, it's unusual for a young man to have the vertebrae collapse so much. Falling out of a tree probably shattered it. He lost the anterior integrity, which is critical. And then that combined with his posterior ligamentous injury allowed him to kyphose and tether his cord over the fragments that were in the narrow canal. It's a little bit unusual because his myelomalacia extends above and below the posterior fragment, which makes you wonder whether he really was neurologically intact when he came in the first time. If you look there, it goes way up and above. There's a lot of sort of penumbra of surrounding ascension and descension of that injury. And so I bet he had some injury and cord contusion when he came in. And so it's already damaged. So anytime, it's been my experience, they get tethered over a kyphotic bump or a piece of bone there, there's a pretty good chance that they'll get collapsed like he has. And so I think the injury was more severe than first suspected. I think it involved all 3 columns, the anterior, the middle, and the posterior column, if you use Denis' classification. Holdsworth would be all the anterior vertebral body or the posterior structures. Either one is adequate in my feeling. The TLIX basically is just a grading, and I suspect this probably would have graded more of a 7 or 8 kind of thing because he had neurologic, he had both an anterior and posterior column. And so I would have, obviously in an ideal world, would have done him right away. And I think he probably at his age would have just reconstituted the body and healed up pretty good without a lot of elaborate, more extensive surgery. But so that would be my assessment of it, Jens.
I love your attention to the PLC, obviously. And by the way, shout out and good morning to many of our colleagues around the world, including Drs. Fayaz, Shamandal, Cartararo, Senegor, and Dr. Davis. Always love having you. And Dr. Davis, shout out to you for your support. Quick question, 2 more questions, and we'll have to move on for cases. Number 1, in the big picture and realizing how important the PLC is, and this is a physiologically young man of thin build, do braces, do TLSOs work for, let's say, not critical, meaning type C injuries? Do braces have a role for purely compressive injuries like compression fractures and burst fractures, or not, like what our Canadian neighbors tend to say?
Well, I think if you look at Kirkham Wood's article, if they're a pure burst injury, I don't know if they had an MRI available. I'm quite certain the PLO would have been wiped out on this gentleman. But if they have a pure compressive burst injury and they're neurologically intact, he showed that braces work better than surgery at a 10-year interval. follow-up.
No braces.
And
No
they went
brace.
even further in Canada, like you mentioned, and said that we, for those kind of injuries, don't need to brace them. And so, I mean, I probably would tend to brace it because I feel like I'm doing something. But that would be, if it's a pure burst injury, compression injury, generally bracing is optional. But they tend to heal well without aggressive surgery.
And then, Jeremiah, you did a very nice job fixing this, recognizing this. I think it's a very instructive case and showing the interrelationship of biomechanics and neurology. And as human beings, we're so vulnerable because half of our injuries happen between T11 and L1, yet there's this thing called conus medullaris right in that area, exposing it to injury, even late injury. So the question to Dr. Dimar, Professor Dimar, is how much deformity correction, how much anterior column reconstruction do we actually need? So Dr. Jeremiah Lechema did a very nice job with some deformity correction and a nice decompression. The patient did well. But how much true deformity correction do we need in the thoracolumbar spine?
Are you asking me?
Yes, Dr. Dimar.
Well, at T12, you should have 0 degrees of kyphosis. So it looks like he's pretty close to that, which is good. I think he'll get away with this gentleman because he's 20 and he's healthy and he's likely to fuse posteriorly. I would like to see, I would always study these people afterwards to make sure I reconstitute the canal and that there's no anterior, the anterior fragment isn't, providing a speed bump or at the conus and everything. I tend to probably potentially, he got a nice correction. He must have done some posterior column, like a PCO on this, take out the facets to get it reduced, which would work fine. And I think he'll do okay with a good posterior lateral fusion. One word about the conus. The conus is a hindbrain. It has a large cellular content. It's responsible for your rhythmic stepping and moving in your legs, just like dinosaurs. If you look at them, they have 2 brains. It's something that's because we're going to talk about this, phylogeny, in other words, a whole species or a group of species. It's been carried out through animals for millions of years, and it requires we can put animals that are paraplegic on a treadmill and they'll step because of it. So it's like a mini brain. So it's larger, more cellular content, more subject to injury, controls bowel and bladder control and all those kind of things. So that's why it doesn't tolerate a bump, a bone sticking back against it. It'll tend to get chronic change, particularly when they kyphose. This is a little more of the pathology. So I would tend to probably try to remove that. And I think whatever you're good at, whether it's anterior, doing an anterior corpectomy and have a good approach surgeon available. If not, I think a costotransversectomy type approach or a VCR, if you want to extend it, would be another option, particularly if you weren't able to get him straight. But he looks like he got decent correction here, not completely corrected, but certainly significantly corrected. So I think he'll probably do okay. Would be my
Final
opinion.
question, how did you do the posterior deformity correction? Did you do a posterior column resection or anything like that?
No, I didn't. I just did distraction, and you were actually able to get that. I was actually surprised. It wasn't.
He did a decompression, right?
Yeah,
Posterior
I did a
decompression.
Yeah. Okay. Well, you probably took a lot of the facets out, so.
And neurologically, how'd the patient do?
The patient, before I came, had seen him like once because it was just 3 weeks after surgery. So wasn't much change. He was happy. He was saying that he's feeling less numb. But so I will see him after and see how he does.
Yeah. Great case.
Thank you.
Good.
Dr. Mark Kramer, neurosurgical colleague from the University of Wisconsin, here for the year and hopefully for longer. And he's done a great job, and he is running a very cool scientific project on a next generation patient-reported outcomes. I'm not going to reveal much more. We're very much looking forward to seeing the results that he'll feature for the first time at the AO Spine Fellows meeting in Banff, end of this month. And I want to recognize Ben Rupp, our AV specialist, and we had a very momentous tumor course. So, fast forward.
Excellent. All right.
First world problems, right?
Yeah. So thank you for the introduction. So this is a 6-year-old gentleman that we treated actually late last year. He presented with progressive mobility issues over the course of a year or two, to the point that when he presented to us, he was using a cane. Specifically, he was reporting numbness with walking, and he also reported that he was feeling he couldn't stand up straight. He also had some issues bending over. Had a significant comorbidities, specifically, as you'll see in the physical exam, he had some obesity, which we had to manage preoperatively. He had a previous L3 to 5 fusion about 8 to 9 years ago. He also had bilateral hip replacements. He's unfortunately not too active right now or before surgery, but previously enjoyed playing golf. As you can see here, he's a pretty large gentleman, 138 kilograms, BMI was over 40, and he had some kind of bilateral lower extremity weakness, specifically a little weak in the hip flexor, and his EHL was also somewhat weak as well. So here's his pre-op plane films. You can see the previous fusion. On flexion extension, no significant motion, but there is a spinal listhesis which appears static on flexion extension. And on his scoliosis films, you can see he's got a mild sagittal plane deformity. His SVA is 5 centimeters. And I also show the MRI, which shows some adjacent segment degeneration at L2-3. And we have a cross-sectional T2 image as well at that level. Down at L5-S1, of note, this patient did have some transitional anatomy. We're calling that lower level L5-S1. He had some foraminal stenosis at that level as well. And based on his measurements here, you can see he's got a fairly high pelvic incidence, and his lumbar lordosis is nowhere near that high. This is his CT myelogram that we obtained preoperatively, and just shows that there's a complete absence of contrast around that area at L2-3. So in summary, 60-year-old gentleman, intractable back pain, neurogenic claudication. He's got an iatrogenic flat back. He's got a fairly high pelvic incidence and a fairly low lumbar lordosis and significant stenosis above his previous fusion.
So Dr. Dimar, so thank you for this nice presentation, Mark. This is a dime a dozen. I'm going to see about 25 to 30 patients in clinic later today, and I'll have 5 to 10 patients with exactly the same story. Are we doing a grave disservice to our, especially lumbar spine, in our biped population by fusing them in the presence of degenerative disease? I'll just put that question out categorically.
In a perfect world, the answer would be yes, we are doing them a disservice, because if you've been in practice long enough, you'll see that every successive level you fuse results in a significant amount of disability. And once you go over about 2 levels, and this is like, I see this too all the time in my own population, I've learned that there's not a lot you can do about it, because it's just one of those genetically based diseases along with environmental. This guy's overweight, and there's no question that probably this kind of disease is much more common now than it was 50 years ago when the population wasn't so morbidly obese. So it accelerates it, and every level you do accelerates it. So yes, we are doing them a disservice, but we're stuck with the consequences of their lifestyle and our surgeries. And so you neurologically on this, so that would trump what we're talking about here, so you'd have to address that.
Would you feel comfortable just decompressing this gentleman at that affected, let's call it L2-3 level, rostral to the fusion, or is this basically bound to just continue the fusion disease rostrally?
I think that if you just do a decompression in order at that level where the facets are sagittally oriented, where by the time you get them decompressed, you've sacrificed a good portion of them, and you'll destabilize them in the light of that little bit of listhesis, that you'll get a temporary improvement for less than a year, and then you'll be back to fuse it.
What do you make of our endoscopy colleagues who claim that they can decompress these lesions without destabilizing the spine as much as we do when we do even midline sparing bilateral hemiliminotomies?
Well, that's predicated on how long they follow the patients. So if you only follow the patients for 3 months, your results are 100% good. But if you follow them longer, they're going to be poor.
That's very funny. There you have it, Mark. Let's drive it forward. So we did fuse
That's
him.
right. So yeah, we did. So we actually discussed potentially doing a decompression alone and a Coflex for this gentleman. But we felt like some of his complaints were actually related also to his sagittal deformity as well. And he has kind of a high pelvic incidence, and his sacral slope's pretty significant. You can see that on our correction here. We actually got a nice,
Excellent.
fairly good sagittal correction, and we're able to place did IDOs at both L5S1 and L23 to get that correction.
Was this done by a robot or human?
These are all human place
man.
screws.
Or
Also notable in this case, we did ask for significant prehabilitation. We asked for him to adhere to a cardiac aerobic workout program, which he did. He actually lost some weight preoperatively, and now he's about 3 months. We just saw him in clinic, and he's actually doing very well.
Yeah, he's actually been quite happy, but I have no delusions about this working its way up the spine over time.
Yes.
And we've obviously spent a lot of time and personal energy in trying to convince these patients how important their lifestyle choices are. The unanswerable question I'm going to ask you, because I consider you a very wise man, anything that you can think of or that we can do to try to minimize this force transmission at the adjacent rostral level? Dr.
Me?
Dimar.
Oh,
Yeah, what can we
first
do
of
to
all,
minimize
excellent
adjacent
job.
deformities?
Excellent job. I'm so glad you addressed L5S1 and also the level of the neurological compression. And I'm extremely happy that you had the foresight to put in iliolumbar screws, because you won't have to worry about that's the foundation of your entire construct that Jens alluded to will happen. You'll need to do this again. What was your PI and what was your lumbar lordosis when you got done?
So our lumbar lordosis increased from 43 to 65 or so.
Excellent.
So we didn't quite get up to
But his lordosis may never have been that high. You rarely ever see a lordosis of 80 degrees with an 81. It's, normal pelvic incidence can be anywhere from 25 to 80 degrees. And it depends on your ethnicity and your genetics. And most guys that have big, deep pelvises are usually kind of big, burly guys that, are like football or as Rousselet taught me, they're rugby players, but very nice. And it's so important. L5S1 is where you get the most lordosis. It's a flagpole effect. So that absolutely should have been addressed. And that's probably where you got a lot of your lordosis. And also, you have to do the iliolumbar fixation, because we've had several iliac sacral fractures and pars fractures in L5 where we didn't go to the pelvis over the last 6 months, which I put in my complication file. And that'll happen. And make sure also, I really like for you guys always to look at the HUs to make sure they're, above 140, 150. Elsewise, you're going to get a fracture, high likelihood they're down around 80 or 90. And what was your original question, Jens? Since I kind of pontificated a little bit.
Adjacent segment disease, rostral. Does rubber banding, in what you're going to tell us about alignment and the
The alignments, every procedure you do, like it was very clear that the 3, 4, and 4, 5 was just a fusion that did not restore lordosis. You see he's got a flat back segment there. Every single level, even single levels, if you're fusing them, I'm a big believer in lordosing every level to what was built into that level when the patient, was 18 years old. And so even if they do wear out above, at least they will not have positive sagittal balance and require, a posterior spinal osteotomy, subtraction osteotomy, or something along that line. You would just simply be able to extend them in a nice balanced way, because that is inevitable. I agree with Jens. And so I think that getting him as lordotic as you can, it'll save you doing some humongous procedure that, quite honestly, does not have the best results. I think the results of subtraction osteotomies was grossly overstated in the last decades. It'll be easy to fix them, in other words. So I'm a big believer in anterior lordotic cages. I can get over 3 levels, 40 degrees of lordosis with 18-degree cages. But this looks great. Great job.
And we left the proximal junction fully intact. So if we have to go back and maybe we can use an interspinous process spacer, interlaminar spacer, something to decompress it. But thank you, Mark. Onwards in rapid fire succession. Appreciate your nice presentation there, Mark. We have Dr. Colin Gold, neurosurgical colleague from the University of Iowa, and he's going to present a complication of mine in the pursuit of deformity correction.
Oh, boy.
Talking about complication files, here we go. Dr. Gold, be kind to me.
Patient's a mid-70s-year-old woman with progressive pain between the shoulder blades, ambulatory with the assistance of a walker, had a fall 11 months ago that resulted in transient inability to walk, which then later regained. Past medical history is significant for breast cancer with a history of a bilateral mastectomy, and patient is living alone in an assisted living facility. This is her physical exam. She has some weakness in finger adduction, grip, flexor, hip flexors, and otherwise intact with some hyperreflexia in the lowers. So here's her imaging. Notice her Hounsfield units at L1 are 71.5. DEXA in 2019 showed a femoral neck T-score of -2. And then you scroll through this. So this is the T4 level that's fractured.
So here we have the nightmare. This patient is actually myelopathic, Dr. Dimar, and she has a intolerable kyphosis. She was managed non-surgical. I can't blame our colleagues. Biomechanically speaking, if we want to brace a patient, picking up on the bracing theme again, what's the brace of choice, if there is one, for a fracture above T6?
Well, you need if you were going to brace you need a CTLSO because you'd have to go all the way up the neck. I find that those are not very effective at this level, and it's tough to really get a leverage arm, like you can down at T12. And I think she would poorly tolerate it because she looks very thin and bony. And there's just no place really to get a lever arm to try to straighten her out. And the second thing, it just won't work. I think you're really left with doing something more aggressive here. I'm surprised your HU units are only 71. I would think they'd be close to 50. But 71 is like a -3.5, which is pretty catastrophic bone health. So, no, I don't think a brace is effective, short and long of it.
Any room for anabolic bone medication treatment in a patient with cancer history? She's cancer-free. We did a full TCNR9 survey and some biomarkers. So she's declared cancer-free, but she had a serious bout of breast cancer. How many years ago, Colin?
It was like over 5.
Over 5 years. So she's
All right. Well,
I don't bone scan.
The anabolic. There's 3 anabolics. There's teriparatide or Forteo, alabaloparatide, which is Tymlos, and then there's Evenity, which is romosozumab as a trade name, and they're very powerful. And there was a black box warning label for Forteo for potential osteosarcomas because they saw it experimentally in studies with the mice when they tested the drug, but that has not been proven to occur in humans. And I know of no instance where it's actually stimulative of breast cancer. It would be more of a bone cancer. And so I would probably, and you have the option of starting the patient, assuming she doesn't have any cardiac disease, which has now been disproven in Japan by their national FDA. I would start the patient on Evenity or romosozumab or one of the parathyroid analogs immediately, because within 2 to 3 months, you'll get a 26% with increase in bone strength, and it starts the day in. It also tends to be the receptors for BMP and PTH are right beside each other. They're enhancing. They work synergistically, and it potentially can even help with bone healing. And so this is a patient that I would immediately get on an anabolic of some sort, because that's the key. The reason she has this disease is not because any other reason, the fact that her bone health's been ignored.
And how long? So here we have a little bit of a race of time. So she's been myopathic for 6 months, something like that. So we don't have to rush her to the OR today. She's still ambulatory, although, and I put her into a tall walker, which I find much overlooked. But how long do they need to have a bit of a meaningful improvement of their bone health?
Well, I mean, if it's elective adult spinal deformity, you treat them for a year. But in a case like this, I think you get a lot of improvement within the first 3 months. There's an article by that colleague of mine, Ben Elder, who's a neurosurgeon from Mayo's, that published along with Paul Anderson, and they looked at a whole bunch of people, and teriparatide was 25% increase in bone strength, which is enough to get them over the hump to hold screws, and the romosozumab was 26%. It works actually faster than the teriparatide, so we do have something in our toolbox to potentially treat this.
Now to gist of the message, and Dr. Gold can tell us in a second what we did metabolically on her, but, or remind me, in fact, I forgot what we did. I should know it. John, how high, how low do we go in a patient with still pretty desperate osteoporosis and an actually concerning loss of ambulatory function? I think we rated her as a corollary of a neuric 4 now at something like that. So she was really getting gait impaired. She was hanging on to her tall walker. She actually liked it, but she was clearly getting impaired in her ambulatory capabilities. So how high, how low, what do you do to get this deformity corrected?
Well, we'll get her on one of the antibiotics immediately. 15% of the people that leave with fractures, only 15% are started on treatment in the perioperative period. And so that leaves, and we know that these people get a natural kind of bone loss from laying around. That's why we get a lot of fractures in the 4 to 6 week acute PJK problems. So I'd get her on that right away, and I would, if I were going to operate on this, I probably would go 4 above, 4 below, 3 or 4 above, 3 or 4 below. I would do a costotransversectomy transversectomy because it's pretty high to be doing a thoracotomy, pretty morbid to do a hook around the scapula. And I think you could straighten her out pretty well. The other thing I found useful is sometimes I'll put these people in Gardner-Wells traction for 4 or 5 days because they'll straighten right out. And particularly if it's more of a, it depends on how flexible it is, and that'll give me a little bit more room in there to potentially do her. But that's what I would do. I would consider using HA screws, or if you like cement, I guess you could do that as an adjunct for fixation. And then I might consider just leaving her, in more of a, you got to have time for the bone to catch up and heal. And that's going to take 4 to 6 weeks. So you might want to limit her ambulation somewhat during that period of time. That may be a radical thought, but you just don't want to get PJK on this because it could be endgame. So that'd be kind of the general outline of what I do.
Wise words, Dr. Gold, hit me.
All right. So she was, I believe, added on to the surgery schedule, not in any kind of truly elective manner. So there was no anabolic agent started before surgery. Did a T2 to T6 laminectomy, T4 corpectomy, I believe with costotransversectomy at one level above, below, and at that level. And then C2 to T10 posterior fusion with cement augmentation of T10 and LIV -1. And here's her postoperative imaging initially in the hospital.
So I did go to C2 because I don't trust an osteopenic patient with that thing called the head, that bowling ball heavy a thing to stop at C4 or something like that. I'm not particularly comfortable with cervical pedicle screws below C2, and we did basically a corpectomy with expandable cages from the back, like what you said. And full declaration, I hate cement, but I felt I had to use it. I did a LIV -1 and an LIV cement insufflation. And we used the largest possible pedicle screws because she, of course, also has very dysplastic, very small pedicles. So we used the largest bore screws, and she had an uneventful surgical course, right?
Yeah.
No neurologic decline. She was very happy with the new position, rebounded pretty rapidly until,
So
surprise, surprise.
postoperatively, still in the hospital for the first admission, extubated, went to ICU for MAP goals, and completed 24 hours of stress dose steroids. So she started complaining of pain in the area where or towards the bottom of the construct pretty soon after. So we got an X-ray and found this on the first upright X-ray, which is already the beginnings of a compression fracture, maybe even burst, we call it, at the T10 level. Ordered a TOSO for all times out of bed and discharged to a SNF on post-op day 8. Patient was readmitted 3 weeks later through the emergency department with progressive lower mid-back pain.
This is her 3-week readmission film?
Yeah.
This is
Okay.
in hospital before leaving. So pretty
Before
much,
leaving. Okay.
yeah, so it was probably like post-op day 3 or so.
I can tell you, we just published a paper where if you see in the hospital plow through of those screws at the this was at the cephalad rostral kind of dorsal at the top level. If you see plow through those screws, it's going to fail. It tells you, it portends the fact that there's a really, I think it was a 60%, 70% failure rate because it keeps going. So that won the best paper at NASS this year. One of my fellows, Siddiq, did it, and you could actually see they'll just simply change their alignment, and we've seen that for years. And that's in an osteoporotic patient. It's a predictor of failure almost for sure. Just FYI, it's being published. Ironically,
We will have to look that up.
Yeah.
So next, so how low should I have gone? Just in retrospect, seeing what we're seeing with the benefit of hindsight, was T10, T11 just
Go back to the original film. No, I mean I guess you went all the way to T10, huh?
Yep.
I don't know. I mean, what should you say? Go ahead and go down. I think it's a function of her bones just so bad, and I now go to her post-op corrected films and drop it. I would have, I mean, if you drop an S2 line, rather a SAV line, from C7, I mean, geez, looking at this, you're going to have to go all the way down probably to whatever it bisects, L3, something like that.
All right, take us forward in the interest of time, Colin.
Yeah. Physical exam, patient's full strength. She has the same hyperreflexia she had beforehand. Here's a
Yeah, look
CT
at that.
prior to going to the operating room. It just redemonstrates the really flexion distraction injury, compression fracture at T10. So we did partial hardware remover T8.
Hey, look at that.
I'm sorry?
I said, look at that. You went to 3.
Yeah.
I guess right.
T8 to T10, hardware removal, laminectomy T9 to T11, 3-column osteotomy, T10, T11 with bilateral expandable cages, use BMP, local bone graft and allograft, and then posterior fusion T8 to L3, and again, cementing the bottom screws and LIV -1.
Since it worked so well the last time. We had a session with UCSF and others in the interesting case conferences about distal junctional failures. I think that's still under-recognized as a complication, and there was no consensus where to stop caudally. I mean, Sig Bervin said we should go to the pelvis, and I'm pretty sure he will tell me that about this right off the bat, and I was just not ready for that, but I'm still not ready for it. We corrected her. For me, it was impressive. I don't know what your thoughts were, Colin. You rounded with me every day. She came in with that fracture, that distal fracture, and she was pretty out of it. I mean, this was something that made her really quite desperate, quite disoriented, almost delirious, unable to be moved. We did this pretty big surgery on her. I don't know how much blood she lost. She actually did quite well in surgery, didn't lose that much. Had no physiologic problems, and she got up and recovered mentally within a day or 2. I think this impact of /opiates /whatever adjuvant medications we're giving them really does not do very well. And lack of mobility is really bad. She got up and moved, and yes, she has that brace on. That's probably not going to do anything. Any predictions? Anything we can do now, John?
You got her on Forteo, right?
We are trying to. This is again. we have significant access problems for these medications. Our bone health service has been dismantled. I don't want to place any blame publicly on anybody, but this is a very significant frustration that we'll have to revisit here, right, Rod?
Yeah, we're working on it.
Yes.
Well-
So far, so good. She left actually very early, and it was a gratifying salvage for right now. And your words are right that the caudal end of our new alignment should intersect caudally a reasonable vertebra. So thanks.
Well, I mean, there are many, many ways to get those medications. A lot of times the companies will do them almost pro bono, particularly the teriparatides, because they're off, the teriparatide's off patent now, and there's even a generic form of it. We wrote the CNS guidelines, I did with some really great colleagues that we published 3 years ago. And since then, multiple of our companies are now paying for teriparatides when they have this kind of bone density issue. So I'm not sure why you don't have that available with United Healthcare and Humana.
Yeah, we're trying to actually get her on that desperately. And in retrospect, I should have probably just written it myself, but I'm hesitant to do that. Last case before we switch to our speakers. Sorry, Nick, we'll postpone your case for a future. And another problem, serious deformity, and this is Dr. Cameron Hooksett, and he's one of our great fellows from DFW area, and love having a Texan here also. And he's going to talk about this 59-year-old male with a pretty ugly spine.
Yeah, thank you. Kind of a contrast from the previous humbling case. This is not to give too much away. Gentleman that's got a longer term follow-up that did very well, but 59-year-old, worsening back pain, progressive inability to really stand up straight, really remains hunched over to relieve his pain for the last 2 to 3 years. He's unable to walk longer than 30 feet and now has to use a cane for assistance. He's tried all of the conservative management treatments without much improvement of his pain. You can see his sagittal scalp film there with pretty significant kyphosis and sagittal imbalance. He had previous 5 lumbar decompressions over 20 years ago that eventually resulted in L3 to 5 radical laminectomies. He does have a significant past medical history of rheumatoid arthritis and no contributable social history. These is his physical exam. You can see he's got some left leg numbness, but preserved motor strength, and as ODI is considerably high and crippled. And you can see he does have a DEXA that's under osteopenic, not technically osteoporotic. And so he was only able to get supplemented with vitamin D and calcium for that. These are his parameters and upright films. You can see he has a normally higher than usual pelvic tilt. He's retroverting his pelvis. He has compensatory mechanisms, including hip flexion. And you can see there's really non-contributable lumbar lordosis there, and a very high PI-LL mismatch. His SVA is about 11 centimeters pitched forward, and then CVA coronally is off by a little higher than 2.5 centimeters. These are his CT scalp films. You can see as he lays down and corrects a little bit, but not really much correction with being recumbent.
All right. And carry us forwards. So as he's going forwards here and showing us the MRI, so I'm rushing a little bit there, Cameron.
Yep.
So pretty bad stenosis and a complex coronal sagittal deformity, only partially correctable, as we see on the opportunistic sagittal films, which are obviously done in a recumbent position. John, full laminectomies. This is a pet peeve of mine, especially in the lumbar spine. Benign procedure or destabilizing? What are your thoughts?
It's ultimately destabilizing. May take a while, but they detach all the posterior lumbar muscles in a lordotic segment where the weight-bearing line's behind the bodies, and removing the lamina essentially detaches all the paraspinal muscles and ligaments, which are responsible for about 30% of your lumbar support. So eventually, you're going to probably get kyphosis there if you do a full laminectomy.
Yeah, I'm not a friend. We've published on it with Mike Lee as the primary author. We did a 6-degree robotic loading my time at UW, and we were always taught that full laminectomy destabilizes the lumbar spine by about 10, 11%. That's the old white and Punjabi estimate, and we actually found something like 25%.
Yeah, that'd be pretty much where the 30% is, yeah.
Yeah, so yeah, it was over 25%, I think, in our series. So we have a complex deformities. Thoughts, I mean, I think surgery, this is a very nice man. He has a bad combination of body weight. By the way, what I find very important, and this is to you, the pediatric deformity surgeon, Dr. Dimar, looking at the torso and the impact of kyphosis in an adult on the upper half of the torso, the heart-lung compartment relative to the lower compartment. Any thoughts on kyphosis and loss of lung volumes from your end?
Well, if I have, well, I go back to his film there. He's not tremendously, he's hypokyphotic, if anything. It looks like he's straightened out to try, in an effort to stand up straight, he's becoming hypokyphotic because he's lost his lumbar lordosis. I mean, I think you're going to see it with really extremely hypokyphotic patients, they'll lose pulmonary function. And you'll see it with severe kyphosis, usually 80, 90, 100 degrees, but you can see he's kind of straight. And if I have any questions, just do PFTs. You'll know right away. It's not a mystery, you know. If they've got significant restriction, then I'd be concerned.
Yeah, we put him on a recumbent bike, the standard Chapman dose of 30 minutes a day plus. So what would you do surgically then? So assuming he has normal PFTs, he has a autoimmune disease, he's a rheumatoid, his joints, his peripheral joints are actually not that bad, right, Cameron?
Right, yeah, everything else well preserved. He's on biologics, history of steroids managed.
I mean, first of all, I prehab him. I think that's excellent. I'd put him on, I'd take care of that bone density for 2 or 3 months because you've got time doing that time. In a perfect world, we would be able to get him on a teriparatide for sure. And analog for sure, and treating for 3 months, maybe rosuzumab, and then I don't think you can correct a deformity like this anteriorly very well. I think it's just too extreme, and he's too loculated, so I think you're probably leaning more toward a subtraction osteotomy, maybe at L4, maybe asymmetrical if you need to get, you know, I'm not sure what his PI was, but assuming it's 50, you'd have to get, you know, 40 degrees of lordosis. Huh?
It's obscured in red lettering on black background. Note to
Sorry
self,
about that.
greater contrast, but that's okay.
Yeah. But I mean, I would probably do a posterior subtraction osteotomy once I got his bone up to strength, and I think a lot of his thoracic kyphosis will just return once you work back to a reasonable level. Once you get that'd be the only way I would think would really be able to fix this.
Cameron must conclude because we have Dr. Dimar and he has a special lecture here.
Yep, sorry, those parameters were copy and pasted from a automated
All good.
AI
No worries.
generated.
No worries.
That's okay. I just can't see it. There you go.
So these are intraoperative films. You can see from the CT and MRI that he has transitional anatomy to L5S1, so we skipped any interbody work there. But multicentric quad intradiscal osteotomies with the 3 levels above the mobile lumbar segments and quad rod construct there.
Nice.
And all the way up to T9. You can see his
Good.
CT scan here with fairly good coronal and sagittal correction that we're very pleased with.
All right. Nice.
Do you have a final standing film? Because he just came back at the 3-month mark on the occasion of?
So this is kind of compare and contrast here with his parameters immediately post-operative with significant improvement, CT scouts. And this is his 4-month out upright films where you can see pretty significant dramatic relaxation of his compensatory mechanism. So no longer hyperlordosing the cervical spine to tilt back with get a better SVA. He's no longer retroverting his pelvis significantly, and knees are not as bent, and you can see overall good upright correction there.
I worry about the top a little bit, Jens.
Yep. I'm hearing, I'm seeing it, I'm hoping, and we are in an extensive proning extensor exercise program, posterior chain enhancement, but yes.
Excellent. All righty.
AP?
No, just
Okay,
have the
yeah.
schedules.
Now, he was actually very happy. He just came back at the 3-month mark, and just the day before, he had taken a big tumble and actually got a lateral tibial plateau fracture from a tumble. So that's the other frontier, the post-tab with trying to improve balance and fall prevention. So thank you, Cameron. A round of applause for our fellows, and apologies, Dr. Minasali, who's proudly wearing his Philadelphia Eagles lanyard. We shortcut you here, but next time. So thank you all for being here today, and our Gold Pass members especially. It's a great honor to introduce a man who needs no introduction, Dr. John Dimar II, professor of orthopedic surgery and neurological surgery at the Norton Leatherman Institute in Louisville, Kentucky. And honestly, one of the people that when I see him on a lecture schedule, I'm watching his lectures because he is a fountain of knowledge of, as you saw, bone physiology, biomechanics, and practical spine surgery done very well. And he's a frequent speaker here, and we always love him because he is really just one of those go-to people in terms of insights. His topic today is particularly compelling. That is how we as human beings are doing this thing called upright posture with our spine and how compatible or incompatible those two challenges are. John, thank you for joining us.
All right, thanks for the kind words. Holy smokes, I'm not sure I deserve them.
Yes, you do.
Let's see, share. Okay, here we go. Boom. All right, I'm going to talk to you about how researchers unravel the mystery of the human upright sagittal balance. In other words, why your upright balance is critical to your survival, since we're a terminal species, just for what it's worth. There's my disclosures, absolutely nothing.
And Dr. M. House of the Zurich Relief Fund.
Little icebreaker.
These are our newly arrived surgeons, Doctors Trowbridge and Greenbaum. Doctor?
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 Doctor? Doctor?
Doctor?
Doctor?
Doctor?
Doctor?
Doctor? Doctor? Doctor? Doctor? Doctor? Doctor? Doctor? Doctor? Doctor?
Doctor?
Doctor?
Doctor?
Doctor? Doctor? Doctor? Doctor? And doctor. Well, we miss anyone?
That's the introduction there. All right, I'm going to take you on a journey through space and time. Okay. I'm going to go back about 10 million years. Kind of like the Twilight Zone.
A dimension not only of sight and sound, but of mind. A journey into a wondrous land whose boundaries are that of imagination. Your next stop, the Twilight Zone.
So we're going to go back and we're going to find out why we're so enamored with the PI and pelvic tilt and sacral slope and how it developed is essentially what this is about. And how did they develop over time? They're so critical for us. And so anthropology requires us to be human evolutionary detectives to discover the clues. It's really important. And I think this is something you ought to look into and just read about. It's kind of fun. It's a little less boring sometimes than reading the same articles again in the journals. So a little bit of definitions. Anthropology is a study of human beings and their ancestors through time and space in relation to physical character, environment, social relations, and culture, versus archaeology, which is a scientific study of material remains, such as relics, artifacts, monuments, the pyramids, King Tut, all that stuff. Now, phylogeny is the evolutionary development and history of a species or high taxonomic grouping, okay, like birds, over time. And so that's more macro, and of course, anthropology may be more micro. So this is what we think about how we developed, and because this is what we were brought up, okay? So in fact, when you look at this, human beings, dinosaurs died 60 million years ago when a giant asteroid hit down to the Yucatan, blotted out the sun for 10 years, all vegetation died, and mammals and birds took over, which are the remnants of the dinosaurs. And so we, in fact, have just been developing essentially over about 10 million years. So this guy here really kind of started off Charles Darwin when he went on the Beagle and ran around the world and ended up in the Galapagos. And he discerned down there, when he looked at the 8 or 10 different islands, that each island had its own flora on it, such as giant tortoises and particularly birds, the finches. And he looked at all of those different birds, and he was astute enough to notice that every one of them had different characteristics as far as their anatomy, their beaks, their shells, or whatever. And he determined that over the previous million years that the Galapagos have been forming, that they had somehow evolved to meet their environment to be successful. It's all about being successful in perpetuating the species. Now, he was heavily criticized for this, but since then, it's been relatively accepted. Now, most structural things like your body and your skeleton, they take millions of years to develop. And if you ever go look at a dinosaur, they have a pelvis that basically has a ball and socket joint for the hip. But metabolic things will develop over 10,000 years. So how do we know this? Well, for example, when we look at lactose, okay, before we became, when we went from hunter-gatherers 10,000 years ago, to forming communities that were agrarian, all of a sudden we started animal husbandry. So we started raising goats and cattle to make milk, which is, by the way, why we got mycobacterium infections now. They were crossed from cattle to us. But we started looking at that stuff, and people started, basically, they had to have milk and cheese. And when you do that, you can have a reliable food source and expand your population. Well, when you get past about 20, a lot of people couldn't tolerate lactose. Okay, so basically, very quickly, around the world in 3 or 4 different places, there was one single peptide gene mutation that allowed people as adults, which is about 60% of the population now, digest lactose. So that's a serious environmental benefit for people that allows us to propagate and form communities. So when we look at gorillas and chimpanzees and orangutans, they really never advanced. They're our primate brothers from millions of years ago, and they're really a completely separate branch from where we came from. But yet 98% of our DNA is similar to orangutans and gorillas. But you can see by looking at them, you notice that they have a very small skull for the brain. They have very long forearms, okay? They have very shallow pelvises, but they still have ball and socket joints and knee joints, but they really are facultative bipeds. In other words, they usually walk on their knuckles. And you can see that here. Is this the way most primates normally walk? We don't walk like that unless you're one of my fellows, okay? At the end of a long day after we've made you do a lot of surgery. But you can see how much longer their arms are. But they have very similar characteristics. And 10 million years ago, we evolved from these because we also were arboreal up in trees, and the world changed and became more grasslands, and we had no more food sources. So we started to evolve mainly in Africa. So it really started 10 million years ago, and the first biped was about 7 million years ago. And by basically about 4 million years ago, we had developed bipedalism. In other words, our femurs were longer, we had an upright balance, our pelvises were deeper, and we could stand up straight. And that allowed us to exploit a lot of different environments. So we were going to be more successful because we had more food sources. We didn't just eat gazelles like a lion does. Okay, we could eat meat, we could eat animal, we could get in the water and all sorts of things. So the guy that really sort of started this was Raymond Dart, and he's the one that discovered Australopithecus africanus, which was felt to be one of our early ancestors with a small brain cavity, but very much similar to us, that existed about 3 to 4 million years ago. And he was a professor down at Johannesburg, and he believed that he was the early ancestors. Well, we went on, and basically we discovered many other skeletons that showed progressively more features of modern humans, and it really took off about 1 million years ago when we had the development of Homo erectus, Neanderthals, and Homo sapiens that moved across the world. So 2 million years ago, you can see the relatively small brain cavity, okay? But about 1 million years ago, all of a sudden, we call encephalization started to occur, where the brain cavity started to get bigger and bigger and bigger. That culminated actually with Neanderthals that have a 1600 cc brain. Well, we have a smaller brain today, and there's reasons for that. Okay. But the bottom line is this encephalization happened because we had freeing of our forearms, that we could make tools, and we could use our hands, and we developed language skills and a lot of other reasons. We had to develop a bigger brain because of how we walk. We need more computing power when we do that. But you can see about 2 million years ago that started to occur. Now, Lucy is the most famous skeleton. It was discovered by Don Johansson, who was a University of Chicago professor in the Far Triangle, which is Ethiopia. And he discovered this skeleton that has remarkably human-like characteristics. And it was assembled by Dr. Owen Lovejoy, who's a professor and writes wonderful articles about this if you want to read about it. And he assembled it, and it looks remarkably like a modern skeleton. It's about 3.5 feet tall. She had about a 375, 500 cc brain because it's 3 million years ago. It hadn't had an encephalization. The humerus to femur ratio was a little bit more longer forearms than what we have, and a lot of other things. She had normal hips she had valgus knees, which is important to get weight bearing over the legs more efficiently. She had lumbar lordosis. She had pelvis and leg bones that were almost identical in function to what we have today 2 million years ago. So you can see the upright posture developed before encephalization and supposedly us getting smarter and everything. She stood upright, she walked erect, and she was an omnivore. She could eat a lot of things, and that was 3.2 million years ago. Okay, now to further prove that they were upright, if any of you have ever heard of the Latoya footprints, they're at Pleiopristocene site in Tanzania, where they found these footprints. And basically, they had walked across a muddy volcanic surface kind of lake. Wasn't really volcanic deposits, and they left their footprints. It's a family with children that they're tagging behind and everything. And they pretty much proved that they were bipedal because their footprint is almost identical to what we would do. So it's the oldest known evidence of 3.7 years ago that bipedal primates were walking around in Africa. Now, over the millions of years, we had the development of Neanderthals. We had the development of Homo floresiensis, which is a very small hobbit-like creature that existed in Java until about 50, 60,000 years ago. And of course, Homo sapiens, and they're the big dog on the planet now. We also have some species that were less than successful, like Homo sapiens, that will tend to be a dead-end genetic experiment. So practical hypotheses, why are we bipedal? It allows for both arboreal and terrestrial habitation. It expands available food sources so we could survive. We can walk miles and miles and miles and migrate. We can carry our young in our arms. It frees up our hands to make tools and to cook and to hand gestures and all sorts of other things. And our spines, as they've elongated, and our rib cages go on off our pelvis, which is what you see with chimpanzees and gorillas, it's allowed us to have a very flexible spine that can bend in a lot of directions. So there's a lot of, Christopher Vaughan looked at primary neurological theories, and it requires less expenditure energy. That's going to be a recurring theme. You get a rhythmic cyclic stimulation that gives rise to bipedal gait. That's the conus. That's what we were talking about when we talked about it earlier. It's almost on automatic once it's stimulated by down signals from the brain. And it just basically created a whole new neurological symptom, particularly the balance system, our proprioception, to make us into more efficient, effective bipedal ambulators. So Hogar Prushkov, who's another great archaeologist and anthropologist, looked at why is it's also advantageous. Its spontaneous mutations may be advantageous. Those tend to be metabolic ones, like I showed you earlier. This took millions and millions of years, 10 million. So lengthening of the legs improved our walking efficiency. Shortening our forearms made us have fine motor things that we can make tools, as I said. Also reduces weight. That all occurred before expansion of the brain cavity. It allows for tremendous energy savings. We'll come back to that as to why flatbacks are so bad. We developed stone throwing and developing forearms, leading to tools, and we could basically exploit any niche in the environment for food, whether it was in the water swimming or up on the side of a mountain or in a tree or on the plains. So it allowed us also to transport our young all across the world. So this basically led all of these things that exist, the primates that exist now, are separated from us almost 10 million years ago. So what we really think is if you listen to the movies, with cheetah, we all came from chimpanzees. That's not true. Our closest relative, in fact, is an orangutan that is similar to the Australopithecus that Raymond Dart found. And of course, that's the closest thing to Homo sapien. And the red hair gene still survives in our population to this day. So human balance. So how can we know this? Well, there happens to be this syndrome called disequilibrium syndrome, where it's an autosomal recessive mutation, where basically they lack all the connections in the cerebral cortex that allow us to have bipedal ambulation and balance, okay? And basically, the subjects can never learn how to walk. They have severe spatial deformities, and they basically turn into a quadruped. So this is one way we can prove that how the brain, because of increased vestibular canals and bigger cerebral cortex, the encephalization, we had to develop this, which is why it developed progressively after we became bipedal, bigger and bigger and bigger, because then we had all sorts of conscious thought and planning and development of modern society and things along that line. And this enabled us to run and travel and move across the planet very, very quickly. Now, this is a really great study by Adam Foster. The study models requirements in humans to walk with. So what he did was he took his residents and he made him walk on a treadmill with an oxygen mask on to see how much oxygen they were using, with bent knees and flexed hips, okay? So as they did that, he would measure their output and walk them on a treadmill. And what's really interesting about this, it was amazing. It cost 53% more energy to walk with bent knees and bent hips because we don't have long arms to put our knuckles on the ground like gorillas do to spread the load. So we have to support and burn more energy to try to fight to hold ourselves upright. Now you know why a flatback hates you so much when you give him one, okay? And so what it really found was human bipedal anatomy reduces the muscle force required to ambulate by 50%, okay? In other words, we're not a four-wheel drive quadruped that uses a lot of gasoline, okay? We're a two-wheel drive Tesla that uses half the amount of energy to walk the same amount of distance. And that's incredibly important to the spread of the human race across the country. So when you look graphically, okay, look at this. You can look at the bipedal chimpanzees. and you can see how much muscle force they have versus what they use versus what we do to walk the same amount of distance. And the same thing's true about oxygen consumption. So now you know why. So humans don't have the sharpest teeth or the longest claws or the most muscle, okay? But we can run the farthest on the planet. We are the only marathon runners. So why is that important? I'll show you why.
Are both at the end of their strength. Neither can go on much longer.
So we can outrun any animal 20 miles, and we can use less energy, less O2, and eventually they'll tire and we'll catch them. And they're a food source, okay? And the Bushmen still do this, okay, in Africa, as you see here, where this man has run 20 miles and run down this kudu for dinner tonight, okay? And he caught up with it eventually, and they actually filmed it recently, and they still do this. This is a huge environmental advantage that we have, that we are the long distance runners, okay? So insight, Daniel Schmidt did a wonderful article, and we originally, as I said, were tree climbers, and we became walkers on the plains because the climate changed, okay? We became basically in Africa, we went to savanna from very thick woods. So we had to develop a gait pattern. And if you watch yourself walk, you're like walking on stilts. Okay, you bend your knee, but when you take your forward stride, you're in full extension and your knee is locked. And you pivot over that like you're on a pole vault. Okay, that requires an incredible amount of balance and stereoscopic vision, which we'll talk about. So we have a relatively stiff leg pattern, and it is absolutely 100% unique to humans. There's no other animal that has this. And so we have a much less of a hip angle and knee angle when we walk. And so when you walk, if you watch somebody, when you leave here today, watch Jens walk out of the place and watch his pelvis and hips in a purely professional manner, okay? And basically watch him and just watch how level his pelvis is and how little energy he goes from step to step. And that's why we're so efficient. So when you watch somebody walk, there's very little undulation of the pelvis as you walk, and the head stays level. That's a huge energy saving mechanism that we have. And it's really called the reverse pendulum type of situation. So how do we get from a quadruped to a biped? Well, this is what a horse looks like. And we've got to basically rotate that pelvis up vertically, and we've got to deepen the pelvis and add a foot to it, okay? Many 10 million years of evolution. So when you look at a gorilla and you put your eyeball right over its head, okay, this is what it looks like. You can see the ribs and the chest and the skull are way out in front, okay? And the pelvis is very shallow and behind him. But see, he's got long knuckles. So he can always go back to walking on his knuckles and he's a facultative biped, and he's really more of a quadruped. Okay, now when you look at a human from the top, this is what we look like. Our head's right smack dab in the middle of the pelvis. That's why when you put somebody on a Mayfield, you put their head right in the middle of the thoracic outlet, hence it's going to be right in the middle of the pelvis. And that's why when you straighten the spine, you make sure the entire spine is located within the anterior posterior pelvic brim and in the coronal plane within the coronal plane also. This is the real meaning of pelvic incidence. It's the depth of the pelvis to get the entire trunk and pelvis inside that pelvis to maintain good sagittal balance, which makes you bipedal, which is tremendously energy efficient and oxygen, very oxygen minimal. So when we were talking about the chest, when you look at a chest of an old monkey, it looks like a dog. It's more deep anteriorly to posteriorly, okay? But when a chimpanzee comes along, the spine starts to invaginate into the chest wall, and the chest increases in width and decreases in front to back, or PA or AP diameter. So by the time you get to be, as you see as it moves in, by the time you get to be a human, the spine is invaginated. That's why the ribs, when you look at them, go behind the posterior spinous process, okay, because the spine has been invaginated because you've moved the entire spine into the center axis to have it balanced within the center of the pelvis. So another adaptive change. When you look at the head, a chimpanzee, the spine attaches to the back of the skull. With Australopithecus africanus, you can see it moves forward so that the head gets more balanced over the center weight-bearing line, okay, C7 plumb line or whatever you want to call it, okay? And then by the time you get to a human, as you see on the right, it's dead center. So that's why your head sits on a point and is pivoting and balanced, okay? And the muscles around your neck keep it in perfect harmonious balance over the top of the spine, over the top of the thoracic spine, and the center of the pelvis, which is why when you get a muscle injury, like from a whiplash, if you want to call it that, you get such symptoms because you lose that balance and one of those important crucial muscles that does that, if that makes sense. Now, as far as encephalization, unfortunately, we've lost brain size. Neanderthals had bigger brains, 1600 cc's, than we did because they were very much isolationist. We're very much communal and very efficient. Okay, so they're 1600 cc's, and we've actually decreased their brain. And we think that is mainly because over the last 3 to 5,000 years, we've lost 10% volume, 300 cc's. Okay, and that's basically, we think that the complex societies, we don't have to remember as much. We don't develop as much and have as much learning, which stimulates the growth of the brain, a lot of people think. Okay, it's going to get worse now because we've got Google. So our brains are probably going to be 200 cc's less in a century or so. Okay, now why is this important? Well, there's a modern fellow-sized brain. Okay, and I just want to point out, this is the size of an attending's brain. Okay, so you guys keep that in mind when you come and train with us. So now muscle development. Over the centuries, and rather millennium, basically you've had migration of muscles that normally would hold you up down onto the pelvis, so that all the muscles around the spine, particularly the lumbar spine, now attach to the pelvis, and they hold us upright. And you can see that here in that basically you'll have migration of all these muscles. You can see the old world, they're actually attached to the spine. Well, in humans and chimpanzees, they actually attach to the top of the pelvis. And that's a migration that took 21 million years. You remember how I told you structural changes take a lot longer. So when you look at a human on the left, our muscles on the back are smaller because we have circumferential hoop muscles, while monkeys have to have bigger muscles in the back because they walk quadrupedal, just like a gorilla or a chimpanzee. So they have to be bigger to hold them up. So some of the changes. The other change is, you remember how I told you that the ribs are shingled? Well, if you look on the left, the ribs actually are over the pelvis in a gorilla because they're leaning forward. Okay, with a chimpanzee, they move up to L3, and with a human, they move all the way up to L1. Why is that? Well, because we're basically completely bipedal. We have to have a very flexible, mobile spine because as you walk, you're constantly adjusting side to side to maintain your center of gravity, or forward, back, and forth, and you're moving your spine 1,000,000 times a day. And having more flexible levels allows you to have better balance and do much more walking, and that's a huge adaptive event. And so that's why we basically had elongation of the lumbar scoliosis, which unfortunately has also predisposed us to scoliosis. So it's all tied together, you can see. So lordotic spines are better for us as bipedal animals. And that's led us back to all the pelvic incidents, and which we'll talk about real quickly here. Basically, when you look at this, you can see a monkey on the left, very narrow pelvis. Remember how I said that? PI is like very small. You go up to a chimpanzee, it gets deeper. You go up to Australopithecus, you see how we're getting up right now. And as the pelvis gets deeper, you get a bigger lordosis, and thoracic kyphosis get balanced because chimpanzees have thoracic kyphosis, but they don't have lordosis. But we develop the lordosis, and that moves the spine back over the center of the pelvis. And as it deepens to when we become normal, now you see we're perfectly balanced, and the spine, the thoracic kyphosis, the cervical lordosis, and the lumbar lordosis are within the realm of anterior posterior brims of the pelvis, balanced. It's all about balance. Now, babies, when they're born, they have straight spines. That's why they're quadrupeds. That's why they crawl. But they're programmed to basically try to stand up straight. It's all genetic. And as they grow, their pelvis gets deeper. They go from a chimpanzee pelvis to a modern human pelvis, and they develop their pelvic incidence, okay, as you see here. Now, monkeys are 25 degrees, and that's because the sacrum tends to migrate posteriorly. The AP diameter of the pelvis gets deeper, okay, with Australopithecus. And then when we get to be humans, you can see, now you see why we get a bigger pelvic incidence. And it's variable between ethnicities and everything. But you can see this is why it goes all the way up to 80 degrees like the patient we showed earlier. And this is what's important. So when you look at a newborn, it's 27, 1 to 9 years is 39, 18 years is 49, and most of the time it averages about 50 to 55, depending on your race when you're an adult, okay? And that, the only way you can break that is to break the pelvis or do an osteotomy. And when you look at all the species, again, apes, 22, Neanderthals, interestingly, they leaned forward. They had a very low pelvic incidence, and they were more robust and just kind of a different, completely different subspecies. And Australopithecus is closer to us, Homo erectus, and eventually modern humans about 50 degrees. Now, why else does the pelvis get deep? This is very critical. As encephalization occurred, if we did not develop a bigger pelvic outlet in our females, we would not be able to deliver children. And our brains are so big at this point, okay, that's why we have plates that are mobile, that are allowed to overlap and compress when we go through the birth canal. And then 50% of the brain growth occurs after birth. Because if we had a fully developed brain with birth, we would get stuck in the canal. So that's one of the other reasons why you can see we get a bigger and bigger, more round pelvic outlet to deliver our children. Other things happen, okay? Our foot becomes plantar. It becomes much more, it becomes less able to grab branches and whatnot, and it becomes more robust as far as the heel pad and the pads across the metatarsal heads. Instead of having walking on our knuckles, which is really true, I know they make fun that orthopedic surgeons walk on their knuckles, but chimpanzees and gorillas do. They actually have finger pads there. We basically developed where we could put our hand flat and basically use our hand otherwise. Also, a primate grip has very long fingers to wrap all the way around a branch to swing, while our human grip is much shorter for power and because we don't have to do that anymore. A lot of adaptive changes. When I talked about the stereoscopic vision, we have very much larger vestibular canals and we have stereoscopic vision. Your brain is programmed that it automatically looks at least 2 steps in front of you when you're walking. And have you ever wondered why you're just walking along and you don't really have to pay attention until you get older like me, and then you're going to fall on your face and do a face plant? But when you're younger, your brain is automatically calculating about 2.5 steps in front of you when you're going up and down rough terrain and everything. Did you ever wonder why your foot's there to climb over the next rock and everything, and you're planning when you're jogging to go around something, or you automatically are ready to leap and jump? This is why, because you have an extensive artificial intelligence programming program in there that's telling you to navigate the terrain 2 steps ahead. Finally, we'll talk about the adaptive changes of the lower extremities. When you look at a knee in like a cow, it's actually 3 surfaces. Some dogs have just one surface. And when you look at the human knee, it's much wider. It has more articular surface because it has to bear the weight that 4 extremities had through just 2 extremities. So it had huge adaptive changes over almost 10 million years. Remember, it's a structural change, not a metabolic change. So it took a long time to develop the bicondylar shape that we have now. Okay, only humans, however, are bipeds and have plantigrade feet and everything. So it's very important to realize that our knees are having scoped horse knees, by the way. Our knees are dramatically different and unique, very unique as far as their anatomy. Now, I just found this out. One of my fellows, Justin Matthew, who's from Columbia, and needless to say, it's a little bit of an offbeat issue, but one of the reasons they say that we developed human locomotion and evolution is because we basically were able to sweat and cool our bodies. And there is some truth in this. And the reason why is that panting is very inefficient, like a dog or like a horse or animals, okay? But we have sweat, and it is the most effective cooling mechanism. So on the plains of Africa, it's 100 degrees. We've got to run down kudos to get food for the family or we're going to die, and our species is going to die out. We develop sweating, which is the most effective way to lose heat. 1 gram of water is 35 degrees Celsius, 580 degrees transferred with 1 gram of evaporation. So it allowed us to have endurance running, which was a huge, and we changed our hair pattern as we lost a lot of the fine hair and became, in most cases, essentially hairless apes. There's some other things I'll just briefly touch on. Like one guy thinks that we had a supernova years ago and it burned up the planet with heat because of cosmic radiation, and it turned our forests into the savannas that were advantageous for the development of bipeds and everything. So that we do know that did happen. We don't 100% know why it happened, but there was fairly massive radiation and proton energy after that explosion. So this is the end game. We are the terminal species. Okay, we're at the top here. Every one of these other species of humans, the Australopithecus group, the Ardipithecus group, the Panatropus group, they're all dead. They either died out because they couldn't compete in the environments they moved into, which were extensive across 4 continents, by the way, okay, or we wiped them out, which is probably more likely, okay? That's where we're at. So the consequence of bipedal is planet, there were multiple migrations over the last 1 million years out of Africa, 3 at least, the last one about 60,000 years ago. Okay, and they moved all over the place, and you can see they're all different kinds of people. The Demosians are in the middle. They were short, Homo sapiens, and of course Homo erectus, a primitive, much more robust type of human. You know, we still may see some of these genes expressed in certain individuals on our planet now because of crossbreeding and everything, but most of them came out of Africa, and they migrated to Africa and back, okay? And basically, the final wave started 120 million years ago, last finished 60 million years ago, and that's really important because that's when the glaciers were here that started to recede about 20,000 years ago, particularly across Northern Europe and Northern Asia, okay? So as we moved across, what allowed them to disperse was the fact that when you have glaciers, the sea is 300 feet less, okay? And that allowed them to walk right across into England, right across the strait into the United States. And in fact, that's exactly what they did 17 million years ago. and they moved across into Alaska, and within 14,000 years, they were all the way to the tip of South America, humans. And these were Homo sapiens, because by then, Neanderthals were dead. We pretty much wiped them out. Now, let's see what time it is. We've got a few minutes here. Anyway, so as a consequence of this, if you look at skeletons of Homo sapiens 50,000 years ago, the upright has some downside. You've got scoliosis, you've got Bastard's disease, you've got degenerative disease, and you can see there are consequences, including all these problems we have now. So although it is a definite advantage, it was never made for us to last to 80, 90 years old. Most of the time, at 1900, the average man only lived to be 47 years old. So we'll fast forward here to the 20th century and what this means for us. In fact, the first person to describe the pelvic indices was a guy by the name of Bowler, the Bowler clamp, for those who know what that is. And he had these pictures in his textbook way back in the 20s. So he understood the consequence of positive sagittal balance. Dubuisset came along, here I was when I was younger, and he talked about the cone of balance. It's really much tighter than that. It's really the cylinder of balance, because you really can't get outside that brim at all without getting problems. It's led to these top 10 list measurements of bipedalism, I like to call it, but you really need to pay attention to the depth of the pelvis there. That's so critical, because everything above there has to be within the confines of the pelvis, okay? And that led to all these that we talk about. So the guy that really promoted this was Pierre Rousselet. He really talked about these. He talked mainly about Madame Boupard, who basically developed these. Steve, my partner, and I, we did the positive sagittal balance. It's bad, okay? Gee, we needed a study to tell us our patients hated us when they leaned forward, you know, but that showed that. And then Frank Schwab came along and said, well, the pelvis and the hips are the ultimate regulator of this, particularly as you age, okay? So those are 3 papers you look at. And finally, in reference to getting your head over your thoracic outlet, Charlie Kuntz showed that and pointed out how important occipital balance was. Unfortunately, he died. Finally, the other paper you need to worry about our upright sagittal bipedal gait is Pensy, and the fact that most of your lordosis, in most cases, because of your pelvic depth and increased sway back, is between L3, 4, and particularly L5, S1, and that's where you need to focus your correction, as you see here, the apex of the lordosis. Important finding of that study. So this is what we should look like. We should have nice thoracic lordosis, nice lumbar lordosis, and we should be perfectly balanced. So what happens to us? Well, as we get older, our back lumbar spine loses, as we showed in one of those cases, loses lordosis, thoracic spine flattens out, and basically, if you can't extend your hips anymore, you lean forward and you get positive sagittal balance, which patients don't like. Okay, and we measure that with the SVA, best measurement in my opinion. Anything over 5 centimeters is probably going to have some problems. And this is what happens. You remember the gorilla? We move our thoracic spine and our head out over the front of our pelvis, and we become a facultative bipedal organism, okay? And that raises our oxygen consumption and our muscle usage, and people just simply hate it. So our mechanism of balance as you get older is this, okay? Basically, you want to take your pelvic incidence and rotate it backwards. It's fixed. And you retrovert your pelvis with hip extension, which is variable from person to person, and the amount of arthritis, and whether or not you've had a total hip done inappropriately with too much anteversion. And we stabilize yourself usually until we die in our 70s or 80s. And this is why if you get a flat back and you fuse the spine, the hip pops out, because you had not enough anteversion to keep it in place. So in summary, patients that develop management malalignment of the thoracolumbar spine, either due to degenerative changes, surgical fusion, or both, resulting in positive sagittal balance, require more muscle force to stand up, have increased oxygen consumption, and complain about the simplest activities of daily living. In other words, we revert to primitive, facultative bipeds that now have too short of arms to adequately support their trunk. In other words, we don't have long arms like a gorilla. So modern humans are not simple bipeds. Let me get rid of this here. Modern humans are not simply bipeds. They are primitive bipeds that gestate fetuses with enormous brains, and the human hip and thigh have been extensively shaped to that end. That's Owen Lovejoy. These features of the spine are evolutionary innovations that suit the human body plan, as well as the evolutionary path and lifestyle of the human lineage. They have supported an upright bipedal species capable of carrying heavy objects and young across great distances, the whole planet, whether walking or running. In this fashion, they have helped our species to more or less conquer the world. That's Aaron Filler. So really, there are numerous theories as to why we have developed an upright posture over 4 million years. Supernova, who knows? Humans are the only true bipeds, not quadrupedal walkers like gorillas and chimpanzees. We have a unique upright posture and a unique stiff leg pattern in our gait. We have an extremely efficient gait pattern, and bipedalism has freed up our upper extremities of the hand that has led to more hand-eye coordination and probably more encephalization of our brains, which has made us smarter. The downside is we are the only remaining species of that entire family tree you saw of bipedal primates. And so we are the terminal primate, which is probably a bad thing. So that ends my lecture there, just food for thought. If any questions at all.
Thank you very much. And the word of the day is encephalization. We've had meaningful glances exchanged, some accusatory, some mocking here in response to that word, encephalization. The terminal species all over. Here's my question. So first of all, fund of knowledge, and thank you so much for putting into visual graphics and big picture perspective our spinal alignment numbers. So much more meaningful to hear it in this context and for the purpose behind it. Much appreciated. Question. So as we age, unfortunately, our SVA droops forwards, our kyphosis increases. How much is active extensor training capable as we have an aging population preventing forward incline that have been identified in several studies with aging? Can we dynamically correct forward slump?
Jen, I don't think your microphone's on.
My microphone's not on?
Here, use it.
Yeah, so as we age, I was worried about this microphone from the start. Kyphosis is well described with aging. Can we effectively counter this forward sloop of or this loss of SVA with aging with a very diligent active muscle training? Or is this just a fait accompli with aging?
No, I mean, you absolutely can counter it. I mean, you reach a point of no return when you get in your 80s, probably. But at least you're in the upright balance, I think there's a lot of things we can do. I think obesity has been a huge crippling thing for the spine. I think it leads to massive amounts of degenerative disease that we did not see century ago, or decades ago, particularly with people that live longer. I think aging, people live so much longer now, their spines just naturally have a finite life cycle on them and wear out. But there's no question that I think you lose 10% of your muscle in a ballpark, just kind of FYI, after the age of 30 every decade. And you can slow that down a great deal by exactly what you said, keeping yourself in good condition, good shape, taking your vitamin D, keeping your bones strong, having those things checked because we have treatment methods, all those things that lead to kyphosis. However, most people, the vast majority of people, if they keep reasonable weight and muscle tone, they will collapse down within that pelvic bucket or cone of balance and be fine because they have adaptive hip extension that will allow them to retrovert their pelvis and stand up straight, which everybody does as they get older. And that's a good thing. And there are a few people, obviously, that probably don't have as much extension that can't do that, and they'll develop positive sagittal balance and get into trouble. But you've seen many a person that comes in with a perfectly flat spine that stands perfectly straight up. So clearly, they're hip adapters, so to speak.
I think the emphasis on the lower extremities is so critical as we have just become, I think, almost too focused on pelvic incidence and ignore the importance of hips, but also knees and ankles. I loved your extrapolation onto the ankles. So tying this together, just a very weird question I'll ask Rod to close us out here, my partner. Do you lay your patients down flat on a table? Is this part of the routine spine exam to examine the hips and the knees and the ankles for their functionality and their range of motion? Should this be the norm for at least initial spine exam?
You asking me?
Yeah, yes.
Oh, yeah. Well, it depends on the person. Somebody younger that obviously doesn't have any problems with this, although it will surprise you. It just depends on the age. I mean, I almost always get, even my lumbosacral films will include the hips and the pelvis. So I routinely on all patients, particularly any surgical patient, measure the PI and lumbar lordosis. And then I may proceed to get a 36-inch film. Okay. But if I'm really concerned about their overall balance, I'll get an EOS study, and look at them and measure them.
Big picture perspective from Dr. Oskuian.
John, that was really terrific. I mean, we learned so much from you. And as a neurosurgeon, I'll be honest, I mean, you guys, the orthopedic concepts, from Dubusse, yourself, it's really, I think, changed our mindset about, balance, and the hip and pelvis are so important and been neglected for so many years. So thank you so much.
We appreciate you very much, John, and hope to see much more of you, and your insights and bandwidth are, I think, literally, I'll reiterate my words from before, and I mean them, unparalleled. So thank you so much for all your insights and sharing your valuable time with us. Appreciate you very much.
Thanks for having me. Hey, one thing. See this, everybody? Go look at this one that just came out, okay? Got a
Very
great
cool.
synopsis of all this.
And the word of the day, encephalization. Thank you.
Encephalization.
There you go.
And remember, we have more encephalization as attendings.
Thank you.
See you. Let's see, how do I get out of here? Let's see, chat, let's see.